Hello, welcome to another session of Digital Slide Review and Sign Out. I'm Dr. Lewis Hassel, and I'm coming to you from the University of Oklahoma Health Sciences Center. And our program is part of the Digital Anatomic Pathology Academy, a joint venture with Path Presenter and the Digital Pathology Association. I'll just mention that membership in the Digital Pathology Association is complimentary to those in training, as well as to individuals from developing nations. And there are a lot of benefits to that membership. But one of which, of course, is full access to the Digital Anatomic Pathology Academy. Our case today comes from a couple of experiences, but a particular recent case of a young woman with recent onset of unilateral, somewhat achy leg pain. Was fairly persistent and not mild. And this sort of raises the question of, if you're taking care of patients, if you have kids in your home, I mean, sometimes they have aches and pains, and it's very difficult sometimes to know what's serious and what's not. And in fact, if you look at the differential considerations for leg pains in adolescents, most of these are very bland or banal things, which either you can explain based on injury or recent activities, or will eventually fade away without much in the way of particular diagnostic efforts or interventions. So, growing pains, they may last for some period of time. Usually they're bilateral, but they're not usually severe, and they do usually wane after a month or two. Maybe intermittent over a period of time. Likewise, Osgood-Schlatter disease, subpatellar pain from the implantation site there can be moderate, usually bilateral again, but not something that has any specific treatment required, either medication or otherwise. Viral syndromes, of course. But then you get into the more serious ones, fractures, particularly stress fractures. Can cause chronic pain and do warrant some investigation and so forth. DVT, septic arthritis, and of course, the rare tumors. So this list of symptoms is by no means comprehensive, but it gives you a good idea of kind of where to start thinking and differentiating the various processes. Of course, in our circumstance, pathologists, you don't necessarily know this full backdrop, but you just show up one day and you've got a needle biopsy of a bone. And that's what happened with this patient. Here was this needle biopsy. And as we can see, it's got an intact growth plate here. You can see the cartilaginous tissue here. And there's a very important clue here, and that is that on one side of the growth plate, the bone looks very normal. The marrow spaces are wide open. And on the other side of the growth plate, while there's still bony trabeculae, the marrow looks distinctly different. So that gives us a clue that this is a process that began on one side of the growth plate and is not yet, at least in this section, transgressing the growth plate. As we look at this lesion, we can begin to see that this marrow space is occupied by a mixture of fibrous tissue and what appear to be some calcification, bony-like trabeculae in here. And here's even an area where you have less mature bone formation, not fully mineralized, but sort of an osteoid type of appearance with the associated mild degree of atypia that you see here in some of these areas. So this raises the question, and this is not highly cellular or anaplastic tumor, but it's certainly making an abnormal substance, and you've got this funky looking bone here. So what's going on? Is this a benign process? I've encountered a number of circumstances in my career where I've seen cases in consultation that people were reluctant to make a diagnosis of osteosarcoma because the cellularity was low, it was quite fibrotic, and there was this kind of funny looking bone in between the bony trabeculae. This is a pattern of an osteoblastic osteosarcoma. And it is not necessarily a overwhelmingly difficult diagnosis to make, but in the setting of the potential consequences for the child, the individual, the family, and the relative infrequency with which many people encounter this disease, it can be something that gives the pathologist a little bit of pause, depending, of course, upon the quality of your biopsy, the cellularity of the tissue. If you see an area just like this, you may go, well, is this some sort of funny osteoblastic process, maybe an osteoblastoma or something of that sort? And this is where it's especially important for the pathologist to be a diagnostic colleague with the radiologist. So a specimen like this really shouldn't be interpreted in the absence of the radiologic findings. And the reasons for this is that radiology is really kind of the gross examination tool that you as a pathologist can use. And making a biopsy diagnosis without considering the gross features, well, you wouldn't do that in virtually any other organ. And if you do it in bones, you're likely going to make mistakes, because the radiograph can tell you what the margins are like, can tell you what kind of product the lesion is making, and it can also show you kind of the behavior over a period of time. Those can all be predicted from how the radiograph appears. So let's take a look at just a couple of simple radiographic images from this patient. So here it is. We see this tumor occupying the metaphysis of the tibia. Here you see the growth plates not completely fused, but you can see she's getting close to that skeletal maturity when those plates are going to fuse. But as we look closer at this lesion, you can see that the margins are by no means distinct. And in fact, the lesion has elevated the periosteum here. You have so-called Codman's triangle, and probably you've got penetration into the soft tissue. Now, of course, on plain films, you're seeing a two-dimensional projection of a three-dimensional object, and that is complicating your view somewhat. But by virtue of the obscuring of the tibulofibular junction here, the extension into the interosseous space here, and the fuzziness of this margin within the bone, I think you can predict that this is a lesion which has an infiltrative or an aggressive appearance. It's making bone, it has this matrix appearance. And so a radiologist would most likely say this looks like an osteosarcoma. Well, here's the MRI, which confirms some of that impression of a tumor that extends beyond the bone. And here you can see it sort of beginning to engulf the fibula. You can see the abnormal appearance within the marrow space, the sort of obliteration or alteration in the cortex, as you see here, around this portion of the bone. So let's go back to our biopsy here again and look at here another section, just to review kind of what we're seeing that's helpful here. We see the intact bony tissue. It's not destroyed. This is a process that is infiltrating through the marrow space. And those processes usually are dangerous and not to be ignored. We see that this is making an abnormal bony matrix. And just looking at these, trabeculae in here, these are abnormal. This is tumor bone, not, just dysmorphic bone of a fibrous dysplasia or fibrous cortical defect or something of that sort. And then we look at the stroma. Now, typically in osteosarcoma, you like to see osteoid and you like to see some atypia. But here the atypia is relatively muted. There are a few funky looking nuclei around, and we saw some in that section previously, but they're not overwhelming. However, having seen the radiograph and now seeing what this is doing and its behavior in the bone and the kind of tissue that it is, it should not be a difficult step to make the diagnosis of osteosarcoma. Osteoblastic sclerosing osteosarcoma forms new bony trabeculae within the bone that often are relatively low in cellularity. This is not an uncommon appearance. This is a lesion that is usually central within the bone, and its behavior is that of a conventional osteosarcoma. It's a high-grade tumor. But, and here's the caveat and the challenge, from a pathologic standpoint, the diagnosis may be delayed if we ignore the radiographic appearance and are deceived by the relatively paucicellular stroma that we see associated with this osteoid and bone. Of course, the differential diagnosis of an osteoblastic lesion can include a central and low-grade osteosarcoma, though that typically is a little bit older patient and has quite a different appearance to the bony trabeculae that are formed by the tumor. And then other osteoblastic lesions like osteoblastoma and osteoid osteoma. But those have a more characteristic osteoblastic appearance around the bony trabeculae rather than this appearance that we've seen in our case. So with those summary words, I'll conclude this sign out. Our sign out is an osteosarcoma, conventional high-grade, sclerosing and osteoblastic pattern with evidence of extraosseous extension, at least radiographically. And with that, thank you for joining us. If you like this, please, you know the drill, hit that subscribe button and like it. That'll help other people to find the video and find our channel. We hope that you find this material useful and both in your practice and in your teaching. And as you continue on in your profession, we hope that it will be a reminder and help to you in caring for your patients. That's what we do, is care for patients. So until next time, thanks so much for joining me.